We'll start soon in 3 minutes, inshallah.
طيب. يا احمد.
ايوه دكتور.
انا بعد ما اقدم الدكتور سمير على طول اعمل شير سكرين. ها
مظبوط.
السلام عليكم، مساء الخير جميعا.
النور.
أنا I'll stop my video لما يجي إن شاء الله دول. I hope that's okay.
احمد،
ايوه دكتور.
بعد ما اخلص انا اطفي فيديو ولا اخليه شغال على طول؟ فيديو اوديو؟
محاضرة؟
ايوه
لا، لو كان ممكن تفصل الفيديو بعد المحاضرات حضرتك تقفله على طول.
ممكن اطفي الفيديو والاوديو. اوكي. بس انا
السلام عليكم.
موجود.
ازيك دكتور هشام؟ ازي حضرتك؟
اهلا رامي، الله
ازي
يخليك.
حضرتك؟ وحشنا كتير والله. الله
اكثر، الله
يخليك،
يسلمك.
ربنا يكرمك، ربنا يبارك في حضرتك. كله تمام، ربنا يبارك فيك. السلام عليكم دكتور سمير، دكتور حامد.
السلام ورحمة الله، يا أهلا وسهلا. الله
الله
يسلمك.
يخليك، ازي حضرتك؟ الله يبارك فيك.
الله يكرمك إن شاء الله.
الله يخليك، شكرا دكتور. السلام عليكم.
Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues, dear participants, I think it's our pleasure that we are going to start our new, the third webinar about the update of hormonal management and oral contraceptive in reproductive gynecology and male infertility. This is our third webinar. The first one was about COVID-19. We had more than 10,000 participants. And our second one about OB-GYN refreshment, we had more than 3,000. And this is the third one, and which is about update hormonal management. And I think because we had a great speaker, we had good support from the company, and at the same time from the organizing company Top House Conference. Without you, without the participant, without the good speaker, we could not do anything. First, I would like to say happy Ramadan to everybody. Happy Ramadan for the last 10 days of Ramadan. We are going to take from your time. Thank you for everybody for joining us. Our first speaker, which is Dr. Hisham Arab. He is my big brother, but really I learned from him a lot. When I just started, I learned from him how to organize, how to go for meeting, how to arrange a conference, and really I learned from him a lot, and he's always with us. He's a unique, so thank you very much for Dr. Hisham. He's a consultant of obstetrician and gynecology and prenatology. He will talk about interesting subject, which is new generation of oral contraceptive. Welcome, Dr. Hisham.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على أشرف خلق الله محمد بن عبد الله صلوات الله والسلام عليه. Thank you very much, Dr. Samir, for your kind words and the introduction as well as the invitation. I'd like to thank my colleagues and the attendees for their presence in this special presentation. Well, I'm talking to you from home. As we all know, we have to stay at home, but it is really a pleasure to share some knowledge on a new topic. I call it new generation of oral contraceptives. And mainly here, we're talking about how in history, these and medications has developed over the years, as you see it here. And the first thing actually you can see is the start of I can advance it, yes, the start of the medications, which is really birth control pills, start in the 60s, very early 60s. But then in the 1980s, we witnessed two things. One of them is the identification of the risk of high estrogen doses in those pills. And the second really realization, which is that the benefits of the pill may outweigh the possible health risk that can be encountered, and that's why it has been really very well managed in over the years and accepted. And you can see here that we have maintained from the 90s small doses of estrogen, as well as new developments of new progestogens. But the new millennium actually was particularly showing to us a development or introduction of a very typical advanced progestin type, which has been identified as the dienogest and drospirenone. Well, in this actually slide, I can show you the different advancement of different generation in the progestins as they are synthesized. Starting from norethisterone and levonorgestrel, and then the third generation, and the most recent one, of course, is the dienogest and drospirenone. I'll be talking about the drospirenone as being used in the oral contraceptives. I'm sure Dr. Ahman and Dr. Khalid at the end will be talking about the dienogest for separate use. However, let's start with our famous molecule, the drospirenone. Now, it's a very unique progestin, but when you combine it with ethinyl estradiol, that will make for you a birth control pill, a very good birth control pill, and it has been actually, according to those, manufactured as Yasmin or as Yaz, and I can't tell you the difference, and you all know the difference, I'm sure, but there is a third Y, and I call it the yet to be identified. Well, it is actually, the future is, holding lots of things. I just called it a Y because Yasmin and Yaz start with a Y. So we have here actually the three Ys. But in fact, a Y is not really the letter Y, but I put it as a question for an introduction for my next few slides. So these are constituting the drospirenone features, and this which are really specifically related to its function. Why drospirenone has less water retention and weight gain? Those pills containing drospirenone has less water retention and weight gain. Why pills containing drospirenone has show no acne or hirsutism? And why pills containing drospirenone has more protective effect against pregnancy? So this is a better protection. Now, I'll take all these three in the next couple of slides. Well, to start, let's identify where is our drospirenone. This is the drospirenone progestin. As you can see, it's here. It's a derivative from the spironolactone, which is also a progestin, which you can see here a progesterone. This is the typical natural progesterone. This is the retroprogesterone, and this is the spironolactone, which actually is deriving our drospirenone molecule. Now, our drospirenone actually has also unique features different from the other progestins, even the third generation, like the gestodine or the desogestrel. You can see here the androgenic effect. It has no androgenic effect, and you can see that the others they have. Also, there is no an anti-androgenic effect, while the others they don't have that anti-androgenic. In addition, it has an anti-melanocorticoid effects, as you can see it here, while the others, actually most of them, they don't have. So it's an anti-androgenic, it's an non-androgenic, and also an anti-melanocorticoid. So these specific features can explain why I put the first three questions to you. Well, regarding water retention, why? Well, let's talk about the renin-angiotensin-aldosterone system. As we all know, under the effect of estrogen, which stimulates the liver cycle, causing water retention by producing the angiotensin into the lungs, where it's converted to angiotensin 2, and then through the adrenals, the angiotensin 2 release the aldosterone, and this is the molecule, the aldosterone, that cause the its effect on the kidneys, releasing the renin and water retention in the system, and that's how the weight is obtained. Now, with regard to aldosterone, here it shows that it has actually aldosterone is an antagonist receptor, which is to aldosterone. The aldosterone is an antagonist receptor to aldosterone, and it has even 7 times the potency of spironolactone. So what does that mean? You know, when this cycle reaches the aldosterone effect, here the aldosterone, sorry, comes and break this cycle. It will be competing for this molecule, the aldosterone, and that's why there will be no renin being produced. And as a result, with this break at this cycle, they will have no water retention, no weight gain as a result. Then, of course, what about the anti-androgenic activity? Well, it's been shown that it has actually the aldosterone itself compete or inhibits the binding of testosterone to its own receptors. So it leaves the testosterone outside, while the aldosterone receptors they will link into those androgen receptors here, and that's why there will be no androgen effect on the skin. In addition, there'll be other possibility for its mechanism, which is the suppression of the FSH and IL secretion and subsequent reduction in the testosterone production, as well as increased binding of the endogenous androgen caused by the estrogen, which increases the sex hormone binding globulins, which is holding the testosterone molecules rather than getting spread. Now, what about its effectiveness as better contraceptive effectiveness? We can see here from this graph, this is a study on more than 50,000 women using different type of pills containing different progestins. So we found that you can see the gray one here, the pills without drospirenone, and the red one is the pills with drospirenone. You can see the efficacy actually has dropped, you know, by after 1 year. Over the next 2 to 3 years here, you can see the efficacy is dropping even worse with the non-drospirenone OCs, but it is better effectiveness with the drospirenone. What is really very interesting, we found that there is two types of drospirenone-containing pills, the Yasmin, which is 21/7 regimen, while the Yaz, which is 24/4 regimen, and the Yaz is the green one here. It has even a better protection against pregnancy. So this curve really showing clearly how the drospirenone, even with a similar dose, but just by modifying the hormone-free interval, which is really reduced from reduced from 7 days to 4 days, and adding an extra 3 days of drospirenone-containing pills as well as EE, lead to a better protection in this graph. So we can see here, these are what we see in Yaz, the 24/4. There is an additional 3 days of this drospirenone-containing pills, and as well as EE2. And then we have a special features about the drospirenone that comes really very handy here, which is the 30 hours half-life. It's one of the longest progestin half-life that's been known among the different molecules of progestogens, and this prolonged a bit the half-life with reduced actually the hormone-free interval that definitely will cover any missed pill that can be obtained in the next package, or delaying of using the next package for a day or two, with giving that kind of protection, so the patient will not really have that follicle moved. Well, in addition, it has this kind of reduced hormone-free interval from 7 to 4 days actually cause also reduction in the estradiol fluctuation. You can see here, this is diaz 24/4. The hormone levels stay straight, okay, more or less, it doesn't move. However, here, because of for diasmin or 21/7, because of the stopping of those 7 days, definitely the levels of estradiol or the estrogens will goes up. This will lead, in fact, to some kind of symptoms. So here, with this 24/4 regimen, we can actually reduce the withdrawal symptoms such as breast tenderness and headache. Not only that, but also we know something about the activity of the follicles during the use of the pill. Ovulation is very rare, is actually even almost none, not existing. However, when we compare the 24/4 with 21/7, there is sometimes we see what we call the follicle-like structures like this. Well, you can see it here on this patient using diaz, and you can see the follicles, actually they are small, and all of them remain in that size. While here, you can see one follicle might move further, but it doesn't reach the size or the time or the feature of ovulation. However, there is a mobilization of this follicle a little bit further because of that longer hormone-free interval. So, and you can see here a higher incidence of those follicles. And that's how, when we use the 24/4 regimen, we have a greater ovarian suppression. That means there's a better protection against the conception. Now, one very special feature about the about the Yaz Plus, which is the neurotube defects protection, and here, because they supplemented in the whole pill with 400 microgram of folic that the patient is taking every day. Well, this kind of supplementation actually is quite needed, because this will build up the level of folate in her system while she's been taking the pill. And we have seen from this graph that the incidence of NTD actually drops as the level of the serum folate increases from 3 to 6 to 800 or 900. And we have, it's a very important feature about this is about the neurotube defects, because the neurotube closure occurs about 28 days from conception. That means only 2 weeks after the patient, of the woman, knows that she is pregnant. Well, it's only 2 weeks, but this maybe 2 weeks is not enough for her to build up her folate, and that's why it is a time actually crucial in this thing, and that's why it's a very brilliant idea to take that folic acid throughout the use of the pill till the day when she says, okay, I want to stop the pill and get pregnant. Then by that time, she actually has built up her folic level in her system, and she will avoid having a baby with neurotube defect. One very important concept about the use of the pill is the risk or the possible threats that maybe the patients really worry about, which is either thrombosis or breast cancer. And I can reduce this kind of fear by saying that the risk is only associated with certain factors during the first year of use, during the first 3 months of use, or restarting the pill after a week, after 4 weeks of stopping, or for whatever reason they say will take a rest from the pill, which is really a very bad idea. Or in triple patients, where they have the obesity over the age of 40 and they smoke. So if you have these triple features in one patient, this patient really is not supposed to have the pill, because collectively, actually, we have seen that collectively they may increase the risk of VTE, but in an individual basis, no, the risk will be still low. So we have seen over the past 7 years several studies, the URAS, the ENAS, and the INGREX from Europe and from US. And these are published, done specifically to look at the VTE risk association with the VTE. And you can see here more than 200,000 women included in these studies. And the conclusion, studies confirmed that low dose COC, combined oral contraceptives, have a comparable risk factor of VTE, regardless of the type of the progestin that has been used. And you can see here in this beautiful graph, that table, where the risk, the RR regarding of VTE with a different type of progestin, for you can see here for levonorgestrel and 30 microgram of ethylene estradiol, the RR is 1. And you can see here drospirenone with a 20 milligram of EE is again the RR is 1. So all others are in between, but again they have the same more or less a very small risk associated with VTE. Now, what about breast cancer? From various studies that we have seen all over the time, there has been shown to say that there is no change in the risk of reproductive cancers or breast cancer, reduced risk of uterine cancers and ovarian cancer. But again, we can say that the beneficial effect of oral contraceptives use on cancer patients outweigh the adverse risk. Now, this is a typical study, actually has been done in the very recent also, and it covers the 20 to 49 years of age of women, who are the common users of the pill. And it has been shown that it's only certain type of pills, like the ethinyl diol diacetate containing pills or the triphasic pills, that have may association with high risk of breast cancer. However, other types of birth control pills, including low dose pills, were not linked to higher risk of breast cancer. Well, maybe the British in 2017 said maybe there is current users may have a slightly increased risk, but I want to caution you when you say current users, because maybe the one who's recently started the pill, maybe she's already having a pre-existing nidus of that tumor, which really sometimes take maybe at least maybe a year or 6 years sometimes to be discovered on a mammogram. So that's why we have to be cautious about current users. But in general, they have said that the longer they use, the better the protection, and that's why if a woman takes it for a long time, that even giving better protection against the breast cancer. And the most actually very interesting finding actually is regarding the family history. Actually, if a woman, mother or sister, whatever, had breast cancer, she can use the pill, no problem, no increased risk of using the OCs of breast cancer in case if there is a family history. Not only that, but also if the patient herself is a BRCA1 or 2 carrier. That means she has a family history, she has done the genetic testing, and she was tested positive. Even those ones, they don't carry an additional risk of having breast cancer, as has been shown from a very recent study just a year or two ago. Well, I don't want to take much of your time or my colleagues. I'd like to thank you for joining me, and I'm happy to answer questions.
Thank you very much, Dr. Hisham. We have one question from the participant. They are asking, is Yas Plus available in Saudi Arabia?
Yas Plus, it is available in Saudi Arabia, yes.
Okay. One question that what about post using oral contraceptive during COVID-19? What is your recommendation?
Well, for the problem with COVID-19 is the lockdown, so there is no chance for women to go and see the doctor. But anyway, whoever is using the pill, my advice to her during this time is to maintain the same pill she is using. For new users, maybe she'll need to have what we call the telehealth conference with the doctor, and he can choose a new method of contraception. But whoever is using a combined pill or contraceptive pills, she should maintain or keep that pill used throughout this lockdown.
Thank you very much. There are some questions actually in question and answer. So whenever you have a time, please keep answering it because of the shortage of time. And I would like to remind all the participants that please join us in the YouTube because the Zoom is full, and please continue joining us in the YouTube. Our next speaker, Dr. Hamad Al-Sifayan, he is well-known figures. He is a consultant OB-GYN and reproductive IVF from Doria Medical Center. He is the Saudi Fertility Group President, and he's the Vice President for Saudi OB-GYN Society. He's my boss. So welcome, Dr. Hamad Al-Sifayan.
Thank you, Dr. Samir, and your organizing committee for this excellent meeting in such hard time. And thank you for your nice introduction. I hope I deserve it. And greeting to all the honorable speakers, and thanks to Buyers Company and the organizing committee. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to congratulate everybody for the holy month Ramadan, and I ask Allah to bless us and grant us acceptance in this month and Laylatul Qadr, inshallah. My talk today from Doria Medical Center, as Dr. Samir said. The talk is different from my colleague and friend, Dr. Hisham. It is not the use of combined oral contraceptive pill, it is the misuse. Why is it misused? Mainly because it is counter-medication. Unfortunately, it is considered as headache treatment, gastric upset treatment, or vitamins. It shouldn't be, because it contains two vital hormones, namely estrogen, usually ethinyl estradiol, and progestogen, especially progestin. And this shouldn't be taken lightly. Okay, first use, as Dr. Hisham said, 1960s. So more than 60 years in the market. It is used by more than 100 million women. It is perfect as birth control, and this is why is it manufactured, and it has been licensed for this reason only. Failure rate is perfect, 0.3%, 3 in 1,000 women. Even in imperfect use, like forgetting one tablet, taking it in different times, it does not exceed 9% failure rate. So what do you mean by misuse? It is when it is used for non-contraceptive purposes. We can go some condition, but I'm sure there are more. We will talk about polycystic ovary syndrome, endometriosis, adenomyosis, acne, hirsutism, amenorrhea, menorrhagia, dysfunctional uterine bleeding, ovarian cyst, hormone replacement therapy, and some people will use it for social purposes or religious reasons. We will go quickly through them. Rule in PCO. PCO, what is it? It is a condition caused by hormonal imbalance marked by high status of estrogen. This will cause endometrial overgrowth, may lead to endometrial hyperplasia, and may lead finally to endometrial cancer. So it is a mild condition, but can lead to a serious conditions. The definition, it has been agreed by many authorities, is when you have 2 out of 3, oligo and or anovulation, oligomenorrhea or amenorrhea. This is one. The second one is hyperandrogenism, either clinical or biochemical, plus polycystic ovary picture by ultrasound. Here we have to be careful to rule out other etiological factor for these conditions. And before we label it endometriosis, the morphology of polycystic ovary has been defined as an ovary with total 12 or more follicles measuring 2 to 9 millimeters in diameter and increase ovary volume more than 10 cubic centimeter. So you need good ultrasonographer and good machine to make accurate diagnosis. It is very common. The incidence almost affecting 1 in 10 women, maybe more. Over 7 million women are affected. Unfortunately, 70% were mislabeled and not properly diagnosed. We call them PCO, but actually they are not. They're having different causes or etiology. Less than 50% of women is properly diagnosed. Also, more than 50% will develop diabetes before the age of 40 because they were missed and not treated properly before. PCO is the most common cause of anovulation and failure of infertility. Pathogenesis is also multifactorial and complicated. It can be due to genetics, mother to daughter, and run-in families. Also, lifestyle is most important because obesity and adipose tissue will exacerbate hormonal imbalance. These two will lead to increased androgen with hirsutism, acne, alopecia, etc., and will lead also to insulin resistance, diabetes and metabolic imbalance, also cardiovascular accidents. These both can cause and exacerbate anovulation and estrogen increase, will cause anovulation infertility. Altogether will cause a negative psychological impact, disturbed body image, decreased self-esteem, also depression. The pathophysiology is so complicated and runs in a circle. We don't know when does it start, when does it end. Pituitary, you have high LH, FSH ratio, more than 3. It will affect anovulation, the ovary, chronic anovulation, disturb estrogen, cause endometrial hyperplasia, and also will cause androgen by affecting the androgen level and circulating level, insulin resistant and diabetes, cardiovascular accident by high estrogen. In summary, you can diagnose and by 3 items. One is anovulation or disturbed period, like amenorrhea, oligomenorrhea, etc. Hyperandrogenism, either clinical or biological. Polycystic ovary picture, the one we mentioned. If you have 2 of them, we call it PCO. However, the diagnosis is 2 out of 3, but to summarize it, we divided it into 4 types. Type A, where you have all of them, hyperandrogenism, chronic anovulation, and PCO picture. When you are missing the PCO picture, it is type 2 or B. Type 3, when you are missing the anovulation. Type D is the easiest one, when you have chronic anovulation and polycystic ovary, but no androgenic markers. The treatment, since it is multifactorial, will be multidisciplinary team. Lifestyle, okay, plan and support. Treatment for hyperandrogen and its symptoms. Endometrial protection from hyperplasia. Contraception if required. Fertility counseling if required. Also psychological and behavioral support. Nutritional counseling is important, as well as metabolic screening and intervention when required. So the management simply start with insulin sensitizing agent, particularly if there is insulin resistant. Metformin or similar medication is beneficial when body mass index is more than 25, with metformin with combined contraceptive pills when there is mild androgenic symptoms, and use the least dose, which is 20 microgram. Anti-androgen when the androgenic symptoms are more pronounced, used with contraception. Anti-obesity, whether medication or surgery, will benefit most of the patient with proper counseling. So the indication is very limited, but vital. I'm not saying you don't use it, but just balance it. When contraception is required, when there is menstrual disturbance with acne, it may help. Most important to prevent endometrial hyperplasia and cancer, and when it regulates the cycle, to start assisted reproductive technology. My message for PCO, it is one combined oral contraceptive pills is one of the factors, but it is not the only one. When you use it, please weigh the benefit against other factors, side effects, alternatives, any safety markers. So before you use it, you need a careful balance. Endometriosis, the other condition, combined oral contraceptive pills, among others, treat only symptoms, treat dysmenorrhea or pelvic pain. Non-steroidal anti-inflammatory medication, gonadotropin-releasing hormone agonists to abolish the period, aromatase inhibitor may help. And you see the least side effects. It will not, any of them will not eliminate endometriosis, full stop. It will just reduce the symptoms. The best and the only management is surgical, if you need management. Endometrioma can be excised by laparoscopy or cauterized endometriotic spots. Endometrium invading myometrium called adenomyosis. It's quite common in older paras women, but it can happen at any time, at any age. Combined oral contraceptive pills has hardly any rule, very little. Your choices is symptomatic management or the use of IUD containing hormones, mainly levonorgestrel containing. It lasts between 3 and 7 years, average is 5, and can be for those who want to retain their uterus. If the woman completed her reproductive requirements, total abdominal hysterectomy, whether laparoscopic vaginally assisted or abdominal hysterectomy, will relieve all the symptoms. Acne and hirsutism, combined oral contraceptive pills, of course, can increase sex hormone binding globulin and decrease circulating androgen, and will relieve some of the symptoms like alopecia, hirsutism, and acne. But the main use is to prevent pregnancy when women or girls are using teratogenic medication and they are married, like Rocotin, because it is teratogenic, and shouldn't get pregnant at least 3 months after stopping it. The best treatment, there is not a best, but anti-androgenic medication, dermatological and cosmetic treatment. Amenorrhea, it is taken lightly. Just give the pill, you will get cyclical period. It is true, but this is a false period. It is hardly hormonal withdrawal bleed. Amenorrhea has to be investigated properly. You could have imperformances, defect in the uterus, like PCO, ovaries. It can affect adrenal glands, metabolic, like pancreas and insulin. It can affect general health, obesity or extreme loss of weight, psychological, thyroid, both pituitary and hypothalamus. So before you start any treatment, you have investigation thoroughly. Treat the underlying cause is the main thing. Weight loss, diet, exercise is very helpful and can benefit most of the women. Menorrhagia, heavy period, whether regular or irregular, dysfunctional uterine bleeding, combined oral contraceptive pill is not the best option. Proper investigation. If you have polypectomy through hysteroscopy is the best. Myomectomy, whether intramural or submucous. Also, we have to pay attention to bleeding disorder and to be treated accordingly. Hypothyroidism, adenomyosis can be other factors. Hormone replacement therapy, not all women have all the symptoms of postmenopausal, whether they are premature ovarian failure or menopausal. They have hot flushes, night sweating, loss of concentration, insomnia, hair falling, many symptoms, weight changes. So try to treat symptoms for them. Also use the least expensive, the least risk, like herbal remedies. Some may benefit, but studied ones. meditation, and yoga therapy will relax most women for their stress. Also, when you use supplement and vitamin, if you need to use hormones to protect from osteoporosis in certain condition, continue the lifestyle and herbal. But if you use conjugated estrogen, it is safer and less side effects, 0.625. Ovarian cyst, if it is pathological, the answer is laparoscopy, ovarian cystectomy, whether it is endometrioma, it is hemorrhagic cyst, whatever. If it is functional or fluid cyst more than 5 centimeters, just aspirate it vaginally. If she is married, if single and virgin, you can do it through the abdomen and you get rid of it. If it is between 3 centimeters to 5, less than 3, I ignore it. Between 3 and 5 centimeters, placebo and combined oral contraceptive pills give you the same result. So just give more time. Giving the pill will not resolve it. And if it resolves it, just giving another month will resolve it spontaneously. Some women will use it, or girls will use it for social purposes. They are traveling, they want to enjoy their time without a period, without dysmenorrhea. It is easier to treat dysmenorrhea, and your period will not disturb your recreational schedule. For religious reason, and this is very interesting, my question, is there a need to use combined oral contraceptive pills to delay period and perform Ramadan fasting completely, or do Umrah in certain times you choose, or do Hajj? My answer is no. Because you are rewarded when you have an excuse, like traveling, sickness, having period, couldn't do it, and you are doing it later on at any time, you will be rewarded exactly like you are doing it during Ramadan. قال الرسول صلى الله عليه وسلم إذا مرض العبد أو سافر كتب له مثل ما كان يعمل مقيما. And for jihad, just by niyyah, you haven't performed jihad. قال الرسول صلى الله عليه وسلم في الآية الكريمة سورة النساء الآية 100 ومن يخرج من بيته مهاجرا إلى الله ورسوله ثم يدركه الموت. He did not perform jihad yet. فقد وقع أجره على الله وكان الله غفورا رحيما. You are dealing with Allah, mighty, most generous, most gorgeous. So فاتقوا الله ما استطعتم. So do to Allah and fear Allah as you are able. ويسألونك عن المحيض قل هو أذى. They ask you about period. It is harmful. So why women keep harmful, blood in their body for no benefit? You will get exactly the same reward later on. You have been excused. والله يحب أن تؤتى رخصه كما تحب أن تؤدى عزائمه. Let's go back to medicine side effects. Combined oral contraceptive is not without side effects. Some can be mild to moderate, like migraine, weight changes, risk of hypertension, cholesterol imbalance. Other can be devastating, like breast cancer. There is a slight but definite increase in user compared to non-users. So all women using combined oral contraceptive pills should be tested before, during, and after. More serious side effects, heart and blood vessels. The risk in users is doubled compared to the non-user. 30 per 100,000 in non-user, 60 per 100,000 in combined oral contraceptive pills users. It increased deep venous thrombosis. It increased pulmonary embolism. Also increase stroke and cerebral hemorrhage, and increase myocardial infarction because estrogen very much affecting coagulopathy. Okay, so use the minimal dosage of estrogen. These risks are higher when you use higher dosage, like 50 milligram, or if you have additional risk factor, like strong family history, heavy smokers, age more than 38, weight above the body mass index allowed, prolonged use more than 3 years. We need to be careful. In conclusion, my first question is, when you use combined oral contraceptive pills, ask yourself, is it necessary or unnecessary? You have to answer, not necessary, so don't use it and use alternative. Yes, necessary, you have to ask yourself, second question, is it safe or not safe? To answer. Not safe, don't use it. Look for alternative. Yes, it is safe. Honestly, weigh your cons and pros. Is it worth it? Is the benefit outweigh the risks? My take-home message to you, what Dalai Lama said, if you can help others, please do. If you cannot do that, at least do not harm them. I thank you, Dr. Samir, and audience, and thanks for all the organizing committee. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Thank you very much, Dr. Hamad, for your interesting lecture. One of the participants is asking you, what are the types and classification of PCO?
We mentioned the types, and it has been many times changed according to criteria. I chose the simplest one. They all circle around 3 things: androgen, high level, whether it is biochemical or clinical. That's the main one. Okay, if it is absent, we call it type D. We will go to the types. That's one. If you have one of the others, like polycystic ovary picture, and we said how you diagnose it by ultrasound, more than 12 and follicles, and the volume increased to 10 cubic centimeters. Third one is anovulation or period disturbance. So in summary, the types will depend on the diagnosis. Type 1 is the most severe one. You have the 3 factors: androgenism, chronic anovulation or period, and PCO. When you are missing one, like polycystic ovary picture, you get type B, high androgen and chronic anovulation. Type C, which is midway, high androgen with polycystic ovary. The least harmful one is chronic anovulation, can be corrected by ovulation induction, and polycystic ovary picture. So it is 4 types, 3 criteria. Dr. Samir.
Thank you very much, Dr. Hamad. Just I want to remind all our speakers that there are more questions in the Zoom, and there are more questions in the YouTube. So please try to answer according to your time, because there are a lot of questions which is written in both sides. Thank you very much, Dr. Hamad.
Can I end with the last? I'm praying inshallah أن يزيل الغمة عن الأمة ونلتقي قريبا بإذن الله، وأكرر شكري وتحياتي للجميع. شكرا دكتور سمير.
Thank you. Now, Dr. Hisham, he maybe give.
Mute. Assalamu alaikum wa rahmatullahi wa barakatuh. It's really a great pleasure for me to introduce our host. Dr. Samir Sindi is well known for his excellent activity around the kingdom. And it's really when he started with his beautiful work spreading the knowledge of endoscopy in gynecology, where we started this about 6-7 years ago, and he continued to do this till today. Dr. Samir is an Australian and graduate, and he's very knowledgeable in the field of gynecology. And I'm really happy to see him now giving us a talk on the effect, the contraception, right? Yeah, Samir?
Yeah, about intrauterine contraceptive
devices. Well, okay, without any further ado, I'd like to ask Dr. Samir to start. Thank you, Samir.
Thank you, Dr. Hisham, for your presentation for me, and thanks for joining us. Welcome, everybody, again. I'm going to talk about intrauterine contraceptive device. The background that when you go to the history, that intrauterine contraceptive device is one of the oldest method of contraception. It's intrauterine are the most popular form of reversible birth control. Over 160 million women use it worldwide. They represent 16% of women in reproductive age, while 50% of contraceptive users are in Asia, and 6 to 27 of contraceptive users in part of Europe, while in United States, the percentage start to be increased from 2002, it was 2.4, it goes to 8.5 in 2009. I'm sure now it's more and more, it's increasing. Who started? You know, it started in the Middle East through Arab people. They are putting a small stone inside the uterus of the camel. And even during the period, found it highly effective during the period of high sexual activity. While Hippocrates said that small piece that could put into the uterus of the woman with the help of a small tube can prevent pregnancy. However, the modern use of intrauterine device was started in 1909, where a German physician, Richard, he was first introduced intrauterine contraceptive device as a contraceptive method. Then he reported insertion of a ring made of silkworm got into the uterus. He cut both ends at the level of the external cervical os in order to preserve the possibility of checking and removal of it. 1964. The Cooperative Statistical Program evaluated plastic intrauterine contraceptive device, which made of polyethylene. He designed by laser Margolis and Jack of New York, and concluded that these intrauterine contraceptive devices are safe, were effective method of contraception for use in the National Family Program. In 1974, the progesterone hormone releasing intrauterine device was first marketing, which contained 38 milligram progesterone, release the rate of 65 microgram per day for 1 year. Later on, that started to develop levonorgestrel, Mirena, and releasing intrauterine contraceptive device, and it was effective. The beauty that the period of time increased to 5 years with lower failure rate and associated with less pain and bleeding. And then I put this picture. The patient, she is coming to you, she is asking, she is thinking with her eyes, seeing her eyes about different type of contraception, while the doctor, she is coming to him, he will start counseling her, he know about her detailed history. Then after that, he will choose the best contraception for her. There are two types, as you know, of intrauterine contraceptive device, medicated, that which contain progesterone, and non-medicated contraceptive device. So what is Mirena? Mirena is intrauterine device that releases the progesterone 220 microgram to block the conception. A single intrauterine contraceptive device provide, which is for 5 years treatment. In 2009, the FDA approved Mirena as a treatment for heavy menstrual blood loss. How it works, the mechanism of action, that you see here, that it's the progesterone effect. It causes thickening of the cervical mucus. So by this way, it prevents sperm going inside. It may causes inhibition of movement of sperm. It may causes also thinning of the lining of the uterus. We don't know which mechanism of those one which working, but probably mostly that all working together in order to prevent pregnancy. This is the Mirena. As you see, the advantage of it, that it consists consistent round tip, easy to be inserted. It's also at the same time, it's prevent with inner strengthening, reducing the risk of kinking. And it's one-handed, one left or right, and simple loading. The profile of levonorgestrel Mirena, that it's more than 99% effective. The WHO considered as top tier of effectiveness. It lasts for more than 5 years. More than 80% they continue at a rate at 1 year. Easy to be inserted, easy to be removed, no scalpel needed, and it was numerous non-contraceptive benefit, which included generally reduce menstrual blood loss, increases hemoglobin level, and effective treatment for cases of heavy vaginal bleeding and reduce blood loss from uterine fibroid. The technology that 20 microgram per day releases in the uterus, there is no systemic effect like other hormone as it works more locally, no peak and troughs of levodopa in plasma, a steady low release, small amount of levodopa in the bloodstream, oral contraceptive. Comparing it, the oral is 10 times more in the bloodstream. For neuroplant, it's 2 times more. The concentration of levodopa in the plasma is 125 to 200, and it maintained over 5 years and beyond. When you are looking for generally for advantage and disadvantage of intrauterine contraceptive device, it's once inserted, the advantage that once inserted, it remains in place, it remains effective while in place, it prevents pregnancy for quite long period of time, doesn't interfere with sexual activity. The disadvantage that it may cause bleeding and cramping, increased risk of ectopic for certain type of intrauterine contraceptive device. It doesn't prevent sexual transmitted disease. Its non-medicated intrauterine device is not recommended for women who have heavy or long period. And the indication for intrauterine contraceptive device that nulliparous and multiparous women are at low risk for sexual transmitted infection, indicated psychiatric reason, and patients who are breastfeeding, contraindication to combined oral contraceptive such as history of risk of thromboembolism, and patients who are heavy smoker, patients who have menorrhagia and dysmenorrhea, only with progestin releasing intrauterine device, anemia, used as emergency contraception, used for cases endometriosis. Again, it could be used possibility of adenomyosis and for protection of endometrial hyperplasia after you take endometrial specimen. The side effect generally of intrauterine contraceptive device, that perforation, it's only 1 in 10,000, while expulsion, mostly it happens in the first 3 months. When you look to the rate for the first year, the Paraguard is 3 to 10, while for Marina is less, 6%. At 7 years, the Paraguard is 1.8, for Marina 2.9, but statistically it's reducing, coming down, and strength sometimes it's not visible. Other indication that it's included infection, first 20 days after insertion, the risk is 10 per 1,000 women. Beyond 20 days after insertion, it's coming down to 1.4 per 1,000 women. Patient, she may have cramping, pain, abnormal bleeding, pregnancy. For puberty, the use failure rate is 0.8, while for levodopa, the typical use failure rate is 0.2. Perforation. All perforation, it happens usually at insertion, but it's most of the time it's unrecognized for weeks and months. The risk factor for perforation that inexperienced clinician, immobile uterus, immobile retroverted uterus, presence of myometrial defect, the clinical sign that the patient, she may have pain. The physician, he feels that he lost resistance when he advanced uterine sound or he inserting the intrauterine contraceptive device. And woman, sometimes she's coming delayed with diagnosis. So typically she may present it with other complications like anemia and peritonitis. How you manage those patients? Those patients, you have to do ultrasound for them. You have to check their vital signs, check there is any bleeding, if she has any abdominal pain, and you have to, if you see the thread, you can take it out by pulling the string and you observe your patient. If resistance encountered, you have to stop it and you do for her surgery for removal. It depends on the position of the intrauterine contraceptive device, whether laparoscopy or hysteroscopy. If there is sign of severe uterine bleeding, I saw it very rarely in my life, severe uterine bleeding or vascular or visceral injury, patient need to go for surgery immediately, and the patient, you have to give antibiotic, and don't forget to give the patient alternative kind of contraception. The expulsion, the risk factor of expulsion usually for younger patients who are less than 20, nulliparity, menorrhagia, and severe dysmenorrhea, patient with previous history of expulsion, insertion immediately after the second trimester abortion or postpartum. The management of expulsion, if you see it usually in the vagina or the lower part of the uterus, just you remove it after you do ultrasound and you have to rule out pregnancy. Patient who develop infection, pelvic inflammatory disease, the relative risk is increased by a factor 6 in the first 20 days after insertion, but absolute risk is still low. Mirena is a protective against pelvic inflammatory disease because of the effect of progestin on cervical mucus. You have to initiate antibiotic and removal of intrauterine contraceptive device. With pregnancy, the intrauterine contraceptive device is associated with increased risk of miscarriage, infection, preterm labor and delivery. However, if embedded in the placenta or membrane, removing intrauterine contraceptive device, it may cause bleeding, fetal loss, and fetal trauma. Just I want to remind you, counsel your patient about removal of IUCD if she gets pregnant. Second issue, you have to check that it's ectopic. You have to perform ultrasound and pull the string if visible, otherwise leave it in situ after proper counseling of the patient. Generally, the patient after insertion of IUCD, the recommendation that patient should return to the clinic after her first period. Remember that to review pains. Pains, it reflect about period if it's late, if she have heavy bleeding, if the patient she has abdominal pain or pelvic pain, if she got heavy vaginal discharge, if she is not feeling well, if she has fever, chills, or syncope, if she didn't feel the thread or maybe shorter or longer. The best time to insert IUCD, they recommended that insertion during day 5 to day 10 of her cycle. And this is why, because the cervical os is just only slightly open, so it's easy to be inserted. So this is the ideal time. But however, it could be introduced anytime. They recommended to be insertion during menstruation. Removal, any patient who is asking for removal, explaining of it, intrauterine, if she developed infection, if she got pregnant, the expired date for intrauterine device, if she developed any complication like anemia, especially for non-hormonal, she's not longer, she wants to get pregnant or menopause. The procedure just only grasp the string from the external os forceps and steady to retract it until intrauterine contraceptive was removed. The complications for especially embedded intrauterine device, sometimes embedded into the uterine cavity inside the myometrium, gentle rotation of the string, it could be freely, it's out, if it's stuck or so on. Sometimes you need to do ultrasound. If you can't book your patient for hysteroscopy and removal of IUCD, sometimes you have broken string, so remove it under hysteroscopic measurement. دائما نتذكر والدينا وخصوصا في جميع الأوقات ونقول بسم الله الرحمن الرحيم وقل رب ارحمهما كما ربياني صغيرا واخفض لهما جناح الذل من الرحمة وقل رب ارحمهما كما ربياني صغيرا. رحم الله والدينا ووالديكم. The Mirena is used for indication for Mirena that include contraception, idiopathic menorrhagia, protection from endometrial hyperplasia during estrogen replacement therapy. It may be used for endometriosis, possibly for adenomyosis and endometrial hyperplasia. But my recommendation that you take specimen, endometrial specimen for endometrial hyperplasia before you insert Mirena. It shows how it's Mirena effective in day of the cycle. In this paragraph, after putting Mirena, we compare it, medical therapy with Mirena with giving tranexamic acid or fluoroprofen or oral progesterone. You see in this one, when they compare it, Mirena doesn't cause peak and troughs with oral progesterone dosing. And because oral, it's in the serum, while you see here in the endometrium, using levonorgestrel intrauterine device, it's 808, while with oral preparation, it's 3.5. When you go for the serum to check with the level of levonorgestrel, you see it's continuous in the first, second year, fifth year of Mirena. And while for using oral, it's up to 250 microgram oral levonorgestrel, while it's very low with Mirena. Efficiency of Mirena. That patient who have heavy bleeding, heavy menstrual blood loss, as it's inside, as months go on, it's reducing from 180, for example, it's coming below 100, then coming down, especially as months proceeded, and it's reaching 97. So 97%, which is highly effective. Looking for hemoglobin, patient who's anemic, because it reduces the blood, menstrual blood loss. So it's coming down her hemoglobin, and also for the serum for ferritin. Marina, when you compare it to northosterone, Marina is at least effective as northosterone in reducing menstrual blood loss. So here you see in this graph how much is it effectiveness, and also on the same time the satisfaction of Marina for the patient. So for non-surgical method for treatment of heavy vaginal bleeding, heavy menstrual blood loss, first line it's considered Marina. The second line, which is other drugs, trans-examic, non-steroidal, anti-inflammatory, combined oral contraceptive. Other option, which is northosterone, giving progesterone, long-acting progesterone. This is showing the bar graph comparing Marina to other medical treatment for menstrual blood loss, even the cost. Now everybody is looking for the money, especially after COVID-19 treatment option. You see Marina after the first, second, third year, and this is including follow-up of the patients in OBD. So in Saudi Riyadh, it's highly cost-effective among the treatment of other option. Now we'll go for surgery, comparing Marina to other surgery. This is include hysterectomy, endometrial ablation, thermal balloon resection, microwave. Here, compared endometrial ablation, Marina is 38.8. So it's effective, and also for the endometrial resection. But my recommendation, sometimes we put Marina, sometimes we do for the patient hysteroscopy, we take endometrial specimen, and I recommend to put intrauterine contraceptive hormone 1 inside. So by this way, you protect your patient future-wise for endometrial hyperplasia, and she will have reduce of menstrual blood loss. Marina compared with endometrial ablation, here you see the proportion and satisfaction rate. It's highly satisfied comparing to endometrial ablation, resection, and especially when both together, the percentage will be higher, almost nil. So when you look for as alternative to hysterectomy, here it shows between both proportion of the group for Marina and the control group Marina. The beauty that the use of levonorgestrel intrauterine system, it's a good conservative alternative to hysterectomy. Why? Because her urogenital tract will be intact in the treatment of menorrhagia and should be considered before hysterectomy to other invasive treatment, especially with complication of surgery. When you compare it to hysterectomy, you see in this paper, it shows significant improvement in health-related quality of life, except for physical functioning during the first 5 years of follow-up. And here you see that for functional, that it's hysterectomy, which is patient with surgery, is small, or otherwise it's highly satisfied comparing to surgery. And when you do for high proportion of Marina recipient and those underwent hysterectomy, satisfaction rate was high at the first 5 years and follow-up. However, some of the patients are 40% lower with Marina with hysterectomy at 5 years follow-up, and this is including the cost. You see the cost is a huge difference between both Marina and hysterectomy for follow-up for 5 years. Marina is attractive alternative to hysterectomy in the treatment of menorrhagia. Why? Because they keep avoid surgery complication. Anytime you remove it, she may return to her fertility depending on her age and cost effective. Look to this paragraph. It shows how role of Marina in treatment of menorrhagia. It's highly effective in reducing blood loss, effective treatment, alternative to surgery, effective contraception. It preserves fertility, convenient and cost effective, higher use satisfaction rate, and well tolerated to the patient. The advantage of Marina, especially comparing to other intrauterine contraceptive device, it's convenient, it permits spontaneous sexual activity, dysmenorrhea improve, her menorrhagia, heavy vaginal bleeding improve, provide endometrial protection, treatment for endometriosis. Once it's removed, she return back to her fertility, decrease risk of ectopic because of progesterone, effective and cost effective. The disadvantage, she may have irregular spotting and bleeding. She may have amenorrhea, hormonal side effect. She may have spotting and cramping post insertion. May her partner, he feel discomfort, so you need to shorten the thread. Requires office visit for insertion and removal. Increased risk of pelvic inflammatory disease following insertion. There is no protection against sexual transmitted disease. It can be expelled. Just only in the breast milk, they found that it's 0.1 systemic passage of hormones in the breast milk. The hormonal versus copper, when you compare it, the hormonal, it reduces risk of bleeding, while for the copper, it's increased risk of bleeding. It may both are causing pelvic pain. The risk of ectopic for hormones is 0.02 per 100, while it's for copper, it's 0.25 per 100 patient. When you look to the fertility, it's 19% within 1 month after removal. For copper, it's 30%, but here it's picked up within the 3 months. For Marina, it's 71.4, while for the copper, it's 16 within 3 months, and this is due to hormonal effect. And after, within 1 year, it's 81%, while for the copper, it's 90% within 1 year. These are the contraindications generally for intrauterine contraceptive. It's absolute and relative. Generally, it could be both together. Pregnancy, it could vary. Pregnancy, severe uterine distortion, unexplained vaginal bleeding, current pelvic inflammatory disease, patient with cervicitis and peripheral sepsis, immediate post-septic abortion, allergy to copper, and acute hepatic state of hepatic tumor or hepatic tumor, active deep vein thrombosis or pulmonary embolism, Wilson disease, leukemia. And for relative, it could be increased risk of sexual transmitted disease, and patients who have actually continuous, that one, previous history of multiple uterine surgery, vascular cardiopathy, cervical stenosis or dysplasia, anticoagulant treatment, long-term of anti-inflammatory usage. So in conclusion, I'll say that levonorgestrel intrauterine device, it's proven technology, unique combination features, high appeal, and never has any contraceptive in the last 20 years come remotely close to the Marina in terms of peace, uptake, and sustained use of the comparing to the medroxyprogesterone or patches or others. I would like to thank you for listening, and thank you very much.
Thank you very much, Dr. Samir, for this very interesting and advanced presentation, Marina. We have a question here for you. What is the follow-up of patient using Marina for treatment of endometrial hyperplasia?
The idea that it contains progesterone. But first, as I said in the lecture, please take a specimen, depending on the age of the patient, take endometrial specimen, send it to histopathology, and you have to insert Marina for that one. It acts beautifully. The patient, she will have less loss of her hemoglobin, of bleeding. By this way, she develop her hemoglobin. It will pick up her hemoglobin, and it protect against endometrial hyperplasia. Look for histopathology after the result, and it will be your patient will be improved dramatically. And follow your patient with ultrasound also for endometrial thickness.
Very good. Thank you very much. The second question says, can we use Marina at any age?
I think usually I don't, generally speaking, usually I don't put Marina for nulliparous patient. This is my preference. And I think most, they agree that we don't want to put it for nulliparous patient, but generally we can use it for any age, especially after proper counseling of the patient. So it can be used for at any age.
And does the infertility affected after removal of Marina?
No, at all. After it's removed, and it shows in my slide that it returned back in the first months. After the 3 months, it returned back completely for her fertility issue.
Last question, how come Marina with less incidence of ectopic in spite of positioning reduced tubal motility?
Because the idea that it's a progesterone. So the idea that it reduces the effect of Marina comparing to copper and so on, this is progesterone. It affects actually reducing the incidence of ectopic pregnancy. And that's what they are looking, because patients with other other kind of contraceptive, it's actually raise the incidence of ectopic. When you see the slide, while with ectopic, it's coming with the with Mirena, it's coming down, and this is due to hormonal effect of progesterone.
Well, thank you very much. Do you want to take one more question?
Yeah, go on.
Removing Mirena once the breast cancer is diagnosed? Question mark. This is how it is written. So they're talking about possibility of breast cancer diagnosis. Do you have to remove the Mirena at that time in that patient?
I think I'm not oncologist, but my recommendation, because some of the breast cancer are estrogen dependent. So I think it should be discussed as a teamwork with the oncology and her treatment doctors. But I think it's better that we keep it, because on the same time, some of those estrogen are breast tumor, are estrogen dependent tumor. And you know that by this way, there will be increase in the thickness of the endometrium inside. So the best, I think, to prevent developing endometrial hyperplasia, to keep Mirena inside. But you have to follow your patient with ultrasound, and it has to be discussed with oncology. My recommendation, patient with estrogen dependent tumor, it should be there.
Well, that's all for all the questions. Dr. Samir, do you want to introduce the next speaker, or shall I do that?
As you like, you are my boss.
No, I'm not your boss. Okay, thank you, Dr. Samir. Ladies and gentlemen, we'd like to continue with our webinar. And our next speaker is Dr. Ahmed Saleh. He's a consultant obstetrician gynecologist, reproductive endocrinologist, and infertility. He's a well-known infertility specialist in Riyadh, actually, and he worked in many lead places. He'll be talking about the endometriosis medical management. Dr. Ahmed.
I didn't see the picture of Dr. Ahmed there. So he said he should be in the line. I'll contact him. But meanwhile, I think we'll go for the next speaker. If Dr. Ahmed is not there, so we'll go for the next speaker, if you don't mind, Dr. Hisham.
Okay, I think we go ahead with the next speaker, I see.
Yes.
Go ahead, Samir.
Please go. أيوة أحمد وأنت موجود على هذا.
All right, if Dr. Abdulaziz around here, I saw him at the beginning. Maybe Dr. Ahmed Al-Saleh can join us later on, but we're going to start now with Dr. Abdulaziz Ba'azim. He's an assistant professor of urology at Al-Qura University. He's actually a subspecialist also in male infertility and sexual dysfunction. It's a pleasure really to introduce Dr. Abdulaziz. We have seen him actually giving many presentations in this area, and he's one of the leading Saudi urologists who took the specialty of andrology as well as the sexual dysfunction as a career. And he'll be talking about the forgotten step in infertility assessment. Dr. Abdulaziz.
Yeah. You can hear me now?
Now we can hear you, yes. Go ahead.
Okay. 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 Bismillah. Thank you very much for having me, and كل عام وأنتم بخير إن شاء الله. So today I'll talk about the forgotten step in infertility assessment. I use that just as a segue into just asking our colleagues. I know most of our audience here are gynecologists, from my understanding, to refer the male partner to a specialist in male infertility and why that is important. So we have to keep in mind that infertility affects two individuals. It's sometimes difficult to keep track of that when we only see the female partner, but in more than half of cases, the male partner is involved. And yet the only partner that is evaluated and sometimes is blamed for infertility is the female partner. Indeed, only 20% of partners of women who present for infertility assessment have received an infertility evaluation. And it's importantly true in our society. So in the Middle East, that number is higher than any other region in the world. About 60 to 70% of couples who have infertility have a significant male partner issue. Why is it important to evaluate the male partner? Well, oftentimes the male partner has serious, sometimes even life-threatening conditions. These include hypogonadism, some other endocrinopathies, pituitary tumors, some genetic abnormalities that we'll talk about in a few minutes, and testicular cancer, which is 20 times higher in subfertile men than in the general population. Sometimes we can find some potentially reversible causes for infertility. These include poor lifestyle habits such as smoking, alcohol consumption, sauna, and other factors. And we can detect the varicocele, which I'll spend some time talking about in a few minutes. We can help provide closure for the couple. As an example, patients with some genetic defects, such as the 46XX male, as an example, I have a couple of those patients. Phenotypically men, they are completely normal in terms of their phenotype and their sexual characteristics and their sexual performance. The only problem is that they are completely sterile and they do not produce sperm. And there's no reported cases of conception or sperm production in this type of patient. So these patients, we provide them closure. We explain to them that as far as we know as human beings and our knowledge, according to current medicine, that there is no reported person in your situation who has sired children. And they appreciate that. They avoid unnecessary costs. They avoid unnecessary interventions and procedures being performed. And they know how to proceed with their lives. Sometimes the couple might decide to separate as a result. Sometimes they decide to carry on with their lives based on that and without worrying about fertility. Sometimes they might choose to foster a child. So we provide what I believe is important closure for these type of patients. Some of them, as I alluded to earlier, can harbor some genetic defects that can be transmissible to offspring. And nothing, or a few things are worse than what I faced last week, for example, when I told a man who underwent ICSI that your son has a genetic defect similar to the one that you have, and he will be infertile, such as you were. And it could have been completely avoided if the couple had been, or if the man had been subjected to adequate testing prior to the couple's assisted reproductive technique utilization. Obviously, in most parts of the Middle East, donor sperm is haram, it's prohibited. That leads us to oftentimes need and required to deal with more challenging cases of azoospermia or severe oligospermia, especially non-obstructive azoospermias who have failed previous sperm retrieval attempts. And we see patients who underwent I wouldn't say unnecessary procedures, but procedures that were performed by individuals who were not adequately trained, and that makes our job more difficult. Also, treating the male partner might help us avoid assisted reproductive technique utilization. I know I'm talking to many of the audience members who might be REI specialists. But at the end, we are dealing with a couple who would benefit from achieving a spontaneous pregnancy. That should always be our aim. This would help the couple avoid potentially unnecessary costs. It would help avoid transferring the burden of treatment to the female partner who might be otherwise healthy and the defect is in her husband. Also, it might help alleviate the potentially serious complications of ARTs, although they are not common, but they are there, such as multiple pregnancies and ovarian hyperstimulation syndrome, and the reported, at least in some studies, low and very low birth weight, as well as major birth defects that are seen in ICSI. I'll take a few moments to talk about varicocele because it is a point of contention. And that is because in the past, there was this study that many of my colleagues quote. This was a Cochrane review, probably one of the highest levels of evidence that's out there, that looked into the effect of varicocele repair on subfertile men. And their conclusion was that there is insufficient evidence to support that repairing the varicocele would improve spontaneous pregnancy rates. And this study, when it came in that version, was criticized because it included men with normal semen parameters. It included men with subclinical varicoceles. Subclinical varicocele is a varicocele that is not palpable clinically, but is detected by ultrasound or other ancillary measures. In those updates, it did not include the effect of varicocele repair on semen parameters. So why do I say subclinical varicoceles were included was a point of criticism? Because there were 3 very well designed randomized controlled trials that showed no benefit in pregnancy rate when repairing a subclinical varicocele, yet these were included. An Italian study, it was a meta-analysis, just like the Cochrane review was a meta-analysis. And it included all 8 studies, but 5 of these studies were excluded because of what I mentioned about including normal semen parameters and subclinical varicoceles. And the as-treated analysis showed that there was a significantly higher pregnancy rate in the treatment group, the men who had varicocele repair. There was also another meta-analysis that came around that time that showed that pregnancy rate improved after varicocelectomy. This one included 3 observational studies. And after that version of the Cochrane review that I mentioned earlier by Evers and Collins was published, there was a randomized controlled trial from Saudi Arabia, that showed a significantly higher spontaneous pregnancy rate in the varicocelectomy group. All of this led to the Cochrane review being updated. This happened in 2012, and this time it involved 10 studies, and this time the conclusion was that there was evidence to suggest that pregnancy rates might be increased after varicocele repair. So that's the take-home message about varicocele repair, is that we have evidence to suggest that it does help in achieving, increasing the percentage of achieving a natural spontaneous pregnancy. There's also, the vast majority of evidence says that varicocele repair also improves semen parameters. These include semen concentration, morphology, motility, progressive motility. I won't go into the details of those because it'll take time, but I want to share with you one particular subgroup, which is the patients who have non-obstructive azospermia and severe oligostenospermia. These are particularly challenging men to treat, as you very well know. And this is one study, it was a prospective study, not randomized, and it looked into what we consider now as the gold standard of varicocele repair, microsurgical subinguinal repair. And in this study, both the non-obstructive azospermia patients and the severe oligozoospermia patients showed a significant increase in sperm concentration, and the combined pregnancy rate in these patients was 32%, including a 20% spontaneous pregnancy rate. Again, these are patients who started off as non-obstructive azospermics or severe oligospermics with a count of less than 5 million. Does varicocele repair affect ART success rates? There is a good body of evidence to suggest that it does. This is one of these studies. It's a retrospective study, and it included 306 couples in whom ICSI was performed. And all of these patients, the male partners, all of them had clinical varicocele. In the first group, the men underwent a successful varicocele repair, and in the second group, they underwent ICSI with the varicocele still there. And after varicocelectomy, the semen parameters improved significantly, as did the ICSI pregnancy rates and the ICSI post-ICSI live birth rates. These were significantly higher in the varicocele repair group when compared to the patients who underwent ICSI with a clinical varicocele being present. So when do we evaluate the male partner? My opinion is if you see a member of a couple who has infertility, then you should refer the other partner, meaning that if I receive in my practice a person, a man who has infertility, I, without hesitation, refer his wife for infertility assessment by a reproductive endocrinologist or an infertility specialist. And that goes true the other way. So if you see a man who has been married and who has not been able to achieve pregnancy with his wife after 1 year of regular unprotected intercourse, then this person should be referred to a male infertility specialist. We sometimes encourage seeing them earlier if this person has an infertility risk factor. For example, if it's a man who had a history of cryptorchidism, if the female partner, if the wife has risk factors such as advanced age, we won't tell them to wait longer. Or if the couple has any concerns about the husband's or the male partner's fertility potential. So what do we do when we see a man who has infertility? We start off just like any other patient with a history, and this is extensive. In my practice, I spend 20 to 30 minutes with a new patient who has male infertility. We go extensively. All of these questions we do ask about and more. And then we examine them, of course. If you do not refer them, we will not be able to detect men who are like this. This is a man, and these are his breasts. You can see his body hair distribution. This is a man with hypogonadotropic hypogonadism. And these men typically have azoospermia, and these men benefit from treatment. I have numerous patients such as this, and this is well reported and documented in the literature, who are able to achieve spontaneous natural pregnancy just with medical treatment in this case. Or we can have a patient like this. Believe it or not, this man's right testicle, as you can see, is atrophic. His left testicle is even smaller than the right. All that you see here is a huge varicocele. And this type of man might benefit from varicocele repair. Obviously, laboratory testing is an important part of our assessment, and I'll ask the moderators to please let me know if I'm going over time. The cornerstone of our assessment of men's fertility potential is the semen analysis, the conventional semen analysis. It provides us with information on the functional status of the organs producing semen. As you know, semen is not just spermatozoa, which are produced in the testicle and the seminiferous tubules. It's also a mix of secretions from the epididymis, the seminal vesicles, the prostate, and so on, other organs. And this test, it's very important to realize that this test has its own limitations. It does not account for sperm dysfunction. It does not account for immature spermatozoa, immature chromatin, DNA damage, oxidative stress. It just tells us how the sperm look and how they act. At least 2 separate semen samples are required to label this man as possibly infertile. This is in part because of the wide biological variability intra and interperson. So on your right here, you can see semen parameters. These are numbered, the concentrations from 5 different men. All of these men have actually sired children. All of these men are not infertile. They were able to sire children. And you can see the very high biological variability from 600 as a maximum to much less than that and some of them go to close to 10 million or lower, and they're flat at some points, but then go up again. So between the patients and within the same patient, we see very high variability. It's not like, for example, a CBC or a blood test for a hormone that more or less has reproducible results. It's not without its flaws. Obviously, we measure many variables on semen analysis, and I'll take a moment here to talk about the WHO criteria. So the WHO produces a manual for specifying how to assess and process human semen. It was first published in 1980 and has been updated for the 5th time in 2010. And this 5th edition is actually the first time that has been evidence-based. Before that, the cutoff points that we used to use were based on expert opinions and expert estimates. But in this edition, we used parameters and cutoff points based on actual numbers from fertile men from several countries. The samples used were from 5 studies in 7 countries and 3 continents. And all of the men who submitted samples were recent fathers with a known time to pregnancy. It included results from almost 2,000 semen samples with a time to pregnancy of less than a year. And what we did is, what was done here was a one-sided lower reference limit was used. As you know, when you have a normal distribution, which is the case with the semen analysis, we usually say, for example, for a CBC, if we want to know what the hemoglobin level is, we take the whole population, we take 2 standard deviations from the mean, higher and lower than the mean, and we have 2.5% here and 2.5% here. That's how we reach the 95% confidence interval for our results, and that's why we, as an example for the hemoglobin, if it's higher than our cutoff point, it's considered abnormal, and if it's lower than the cutoff point, then the other cutoff point, it's considered abnormal. But when we're talking about semen analysis, the higher the numbers, we can't say it's abnormal, or it's not desirable. The higher the number, the better the motility, the better the morphology. We expect that it's better fertility. So what we did is we combined these 2.5 and 2.5% into 5% that we put on the lower reference limit. That's how we reached the cutoff points that we used for this test. There's also some measures that were taken. So as an example, we no longer use the A, B, C, D criteria to classify motility. Now it's just progressive or non-progressive motility. And the experts in the previous iterations were actually not that far away, but we'll see that the cutoff points now, after the 5% cutoff point that I mentioned, are in essence all lower than what we used to use in the past, except for motility, progressive motility. There has been criticism, and like I said, it's not a perfect test, and this 5th edition of the criteria has had its own share of criticisms. For one, about 55% of the data that we used came from only 4 Western European countries. The remainder of the results came from another European country and from Australia and from the US. Other areas in the world, including our area, the Middle East, were not included, not represented. In some samples, another system for classifying morphology was not used, so it might not reflect completely and accurately the Tygerberg or the strict criteria that we use to describe morphology. A single sample was taken from each man to get these reference studies, and as we showed earlier, there is a high biological variability. So that is a point of criticism. So semen analysis has its limitations, definitely. We cannot rely on semen analysis alone. About 30% of men who would be otherwise classified as unexplained infertility actually might be shown to have other sperm deficiencies when we assess them by other sperm tests, such as especially sperm function tests, such as DNA fragmentation testing, oxidative stress, and anti-sperm antibodies. And some men with a palpable varicocele, and we mentioned about varicocele earlier, with normal semen parameters according to the semen analysis, might have abnormal semen when we look at their DNA fragmentation rates or oxidative stress rates or levels. So male infertility evaluation, this goes to stress that male infertility evaluation just goes beyond just doing a semen analysis and looking at the cutoff point and saying, yes, you're normal. It has to be complemented by the measures that I mentioned earlier, and partners of women who present with infertility deserve that. The other part of our laboratory investigation is endocrine evaluation. When do we do it? Well, if we usually perform it when we have a patient with an abnormally low sperm concentration, especially if it's less than 10 million, or if the man, when we take a history, describes impaired sexual function, or when there's clinical findings suggestive of endocrinopathies, such as the gynecomastia that I showed you, or when we examine man and find small testicles. Another form of testing, assessing men, is DNA fragmentation testing. This is the new kid on the block. There is a lot of chatter on it. It's, I believe, a valuable tool in select cases, not in all cases. So what happens when sperm is formed in the testicles, is that during the process of spermiogenesis, the DNA of the cell is compacted around protamine, protecting it from damage during transportation in the epididymis and beyond. Some damage does occur, and this can be repaired to an extent within the oocyte's cytoplasm. And infertility can result when the extent of this damage exceeds the the threshold of the oocyte cytoplasm to repair it. And there is a strong body of evidence to suggest that sperm DNA fragmentation is negatively associated with fertility. And this is so much so that the importance of this type of testing has been emphasized and acknowledged by the American Urological Association and the European Association of Urology when they published their guidelines on male infertility. Sperm DNA fragmentation has a negative impact on ART results. It has been shown to be associated with reduced fertilization rates, reduced embryo quality, and reduced pregnancy rates, as well as increased miscarriage or abortion rates. It's not, as I mentioned earlier, not routinely indicated in evaluation of infertile men. These are tests that are sometimes labor intense. They are costly, and the clinical utility of them is in select cases. Plus, there are many tests that are utilized, such as the COMET test, the SCSA test, the tunnel test. So which one do we use has not been agreed upon. Oxidative stress testing in semen is also another form of testing that can be done. There's a detrimental impact. Okay, you want me to?
Yes, conclude, please.
Okay, sure. So this is not universally accepted. Genetic testing we use in cases of non-obstructive azoospermia and severe oligospermia, in which case we do karyotypes and Y chromosome microdeletion. And some cases of obstructive azoospermia, we do the CFTR testing. Scrotal ultrasound is not for everybody. We do it in select cases. As I mentioned, sometimes it overdiagnoses varicoceles. We do use it however, when it's difficult to examine the patient, such as in this case of severe hidradenitis suppurativa, where we cannot examine the testicles. There are other tests that we can use. So to summarize, when we evaluate an infertile couple, there is a collaborative team approach to evaluate and manage this couple. We work closely with our REI colleagues. We should always try to avoid treating the male partner as a source of sperm that we can use for ARTs. They're more than that. They are partners and they are potential patients. And ARTs still have a very important role in managing male factor infertility. We all know that, we all recognize that, but this should be done, as I said, when we work together as a team. Thank you very much.
Thank you. Thank you very much, Dr. Abdelaziz. I think we are running shortage of time, so I'll take only one question. There is one question from the participant, cerebrolysis only syndrome. What is the number of take-home babies? So if you could answer it.
Well, this is a histological diagnosis. Basically, these are patients who present with non-obstructive azoospermia. And these patients will require assessment, as I mentioned. So we would, so they would present to us as non-obstructive azoospermia patients. So we would assess them with hormonal studies. Well, first of all, by history of physical examination and hormonal studies. And if they are proven to be non-obstructive azoospermia, which are the patients who will prove to be cerebrolysis only patients, then we would do a genetic evaluation for them with karyotyping and Y chromosome microdeletion. So the number to give you would not be accurate until we mention this. So as an example that I actually mentioned earlier, some of these patients will have 0% chance of siring children. However, to basically say that, mention or address what I believe you were asking about, if these are non-obstructive azoospermia patients who undergo microsurgical testicular sperm extraction, then the retrieval rate of sperm in this population varies between, well, has been reported as high as 70%, but the realistic number is around 40% to find sperm, 40 to 50%. And so that is the number we have. We cannot say for sure how many take-home babies we'll have if we don't take into account the female factor. As an example, the wife's age and her status. But the number, unfortunately, taking all that into consideration, the number of live births following ICSI for this population of patients is not very high. It's less than 20%.
Okay, thank you very much. I think there are more questions in the webinar and in the YouTube. So if all the speaker will answer it, thank you very much. Highly appreciated. We'll go for.
My pleasure.
Thank you.
So تواصل.
Yes, it's clear. I'll go for our next speaker, Dr. Ahmed Saleh. He's a consultant OB-GYN, reproductive endocrinology. He's our colleague in fertility. He will talk about interesting talk about endometriosis medical management. Welcome, Dr. Ahmed.
السلام عليكم. الصوت واصل لأن الصورة عندي شوية في مشكلة.
Yeah, it's clear. Your voice is clear.
طيب. السلام عليكم ورحمة الله وبركاته. Now let us put the slide as there is no picture. You can see me. Okay, here. Slide is clear now. Hi, Samir.
Yes, it's clear. Proceed, please.
We're going to talk about endometriosis. You know, the endometriosis is a huge topic. There is medical, surgical, IVF, infertility, many things inside this topic. Because of the time limit, we're going to limit only in medical management. This is an introduction just to organize the audience about endometriosis. Is when the endometrial gland and stroma present outside the uterus. When you said adenomyoma, it is isolated endometrial gland in the muscle of the uterus. So there is a difference between endometriosis and adenomyoma. Adenomyosis, when is more than one spot of endometrial gland in the muscle of the uterus. So adenomyoma, we're talking about single one or like small one, or adenomyosis when we have a diffuse piece. They measure this depth of penetration to the uterine muscle to the more than 2.5 millimeter from the endometrium. This is just show you the picture of what we call it global shape uterus. You can see the uterus is enlarged. You can see the ratio between the anterior and posterior uterine wall. Would put the endometrial line in the center. You can see the discrepancy. That's called global enlarged uterus. That's one of the sonographical appearance of adenomyosis. If you do MRI, you can see this endometriotic lesions around in the muscles. So this is the central line is the endometrium. This is the spot is endometrioma. Sorry, adenomyoma. Adenomyoma. Either it can be single adenomyoma or it can be diffuse. We call it adenomyosis. So adenomyoma is a single, adenomyosis when you have a diffuse one. Let's go back to our main topic. Endometriosis affects pelvis in three ways: either rectovaginal septum, ovary, or peritoneum. Ovarian lesion can be superficial or deep or cyst forming, what we call it endometrioma. The causes is being written. This is a disease of theories. Many theories beyond this cause, beyond this disease. The commonest one is retrograde menstruation. The second one is lymphatic and vascular dissemination, coelomic metaplasia, genetic predisposition. We've seen it in the families, we see it in sisters. There is some inheritance predisposing factor there. Immunological changes on hormonal induced. This is a normal picture of laparoscopy. You can see nothing bizarre there. It's normal uterus, cul-de-sac. You can see uterosacral ligament. You can see the bowel and the tube. When you have endometriosis, look at this dark spot. So endometriosis, by the way, is a visual diagnosis. You cannot diagnose patient by symptom or sign. You have to confirm that by looking directly to see the lesion. This is endometriotic lesion in the patient who complain of pain. You can see here, the spot can be very colored, either black or even red color. You can see here, even in the distant metastasis outside the uterus, you can see it at the umbilicus. This patient bleeds at the umbilical side during period. This is one of the clicking hints about the diagnosis. The patient said, I have a bleeding in my umbilicus cyclic. So during the time of the period, I have noticed this one. We will see it in the chest metastasis. That explains lymphatic and hematogenous spread. What symptom bring up the patient? The commonest symptom is dysmenorrhea. Dysmenorrhea is either focal pelvic pain toward the uterus. With chronicity of the disease, the pain will be diffused to be in pelvis. So that's why the patient initially dysmenorrhea, and then later on they develop a generalized pelvic pain. 30% of the patient present with infertility without pain, and then you find out that they have endometriosis. Dyspareunia, whether superficial or deep, mainly deep dyspareunia. Some of them may present with menstrual irregularity. When you work them up, you find everything is normal, then you may think about endometriosis. You do the cystoscope, you find there is endometriotic lesion. Dysuria or hematuria, if the endometriotic invade the bladder. Bowel, the same, if it invade the bowel. So why the patient complain of pain? There is many possible theories behind this one. Because the cyclic bleeding outside the uterus induce inflammatory changes, and that will chronicity of the time make a chronic inflammatory reaction that lead to overproduction of prostaglandin. Some theory explain that increase the cytokines like tumor necrotic factor, interleukin 1, 6, and 8. All of this inflammatory process make the pain. Some theory said maybe the pain due to nerve irritation to the internal organ. That's a weak theory. But the common theory is between the inflammatory reaction and overproduction of prostaglandins. Of how it affects fertility. So the pain mechanism is different from fertility mechanism. In fertility, it can be caused by anatomical distortion of the pelvis. It can lead to ovulatory dysfunction due to this raise of prostaglandin and interleukin factors. It leads to oocyte function, dysfunction, and poor embryo quality. If you compare the embryo quality of normal patient or the tubal factor patient and endometriotic patient, you found it's low quality embryo. It can affect the sperm. It damages the sperm when it comes in the pathway. It reduces fertilization and implantation. So there is two main factors here. One affecting fertility, the other factor affecting pain. When we are treating the patient, it depends on what the patient is suffering from. If the patient suffers from fertility, there is no medical treatment here. You have to go for surgical treatment or you have to go for ART, assisted reproductive technology. If the patient complains of pain, that's the rule for medical therapy. The stages of endometriosis, you know that in American society divided stage 1, 2, 3, and 4, depending on the severity of the disease. This is a chart where is the patient during the laparoscope, you have to fill this chart and then you can say the patient have mild or moderate and severe. So this patient looks like she has a mild case. So I go back to the chart, I make this number between 1 to 5 is mild. I'm just going to flip the pictures and then I'll go to directly to the treatment, medical treatment, because this is the core for this presentation. This is another, you can see dark spots. Here you can see fresh red spots. You can see here white spots. This is stage 2, when there's more starting to more deep penetration or adhesion formation. Stage 2, you can see superficial ovarian or peritoneal defects, peritoneal defects. Stage 3, when you start to have more dense adhesions, you can see the adhesion getting more dense. Stage 4, when you have what you call it carpet of adhesion or blanket of adhesion, more severe adhesion, cyst forming lesion like endometriomas. Now, how would you manage this patient? First, in the first counseling, when the patient diagnosed with endometriosis, we'll tell the patient this disease is treatable but not curable. So you have to live with it. So most of the patients, you have to expect what the treatment gonna do. All what the treatment gonna do is gonna cool down this inflammatory reactions, inflammatory changes by shutting down the estrogen supply, and then the patient will be pain-free. As soon as they stop medication, the pain recurs. So that's why in the first visit, we tell the patient, this disease is treatable, we can tackle pain, but not curable. So there is medical treatment, surgical treatment, combination of treatment, and assisted reproduction. Medical treatment usually for the patient want to release of pain. For infertility, it's different story. So we're going to concentrate on the pain management part. When you put a medical treatment for pelvic pain, either diffuse or focal, you have to put in consideration the age, how old is the patient? Is it patient near menopause or patient away from menopause? Severity of the pain symptoms. Is the patient pain can be tackled by simple analgesia? So forget about any other management. On extent of the disease. Extent of the disease, people think that pain doesn't relate to the stage of the disease. If you said patient is stage 1, have more pain than stage 4. So pain doesn't relate it to the stage of the disease. Maybe stage 4 have no pain, maybe stage 4 have small pain. Severe pain can happen with any stage of this. So stage of the disease, nothing to do with the pain. Patient reproductive plan, is the patient need fertility issue now or later on? Maybe the patient at this time want to control pain, and later on they will deal with fertility though you stop the pain medication. So you have to explain, once they decided about the medication, you have to explain to the patient risk and side effect of that medication. The reason, because this medication gonna take him for long. Patient gonna use this medication for at least 1 year. So that long time of exposure to the medication, you are entitled to have side effects. So you have to tell this patient upfront. Cost consideration, because of the longevity of the treatment. Patient might take this long time medication, so they have to put cost in consideration. These are the pain management options you have. As we said, is non-steroidal anti-inflammatory medication. This is just a painkiller. It reduces the pain for a patient with mild. If the patient tackled with this kind of treatment, so you stop there. If the patient is still not satisfied with this treatment, you go with combined pill. So the first line management is the painkiller and or combined birth control pill. People think that can be used as continuous. So the reason to use it continuous combined pill, do not allow the period to come. But now you can use it even cyclic, can tackle the pain. So you have two options when you are dealing with birth control pill. Either you use it continuous or you can use it cyclic. Both of them works as a first line management. When you go to the second line management, Benazole is an old treatment. It's not used anymore today because it has a lot of androgenic side effects. Remember, patient might use this medication for 1 year. So even 1% side effect after 1 year is going to be coming soon. So that Benazole is not used anyway. The common second line drug now used as long-term medication is GnRH analog without estrogen add-back. GnRH analog is the long-acting form. There's a monthly injection, and now there is a 3-month injection. So there is a long-acting and very long-acting. That is one of the good second line medication. The problem with gonadotropin, long time use, it leads to hypoestrogenic. Not just to cut down the estrogen supply to the endometriosis, it will cut down the estrogen supply to the whole body. You're going to suffer from menopausal problem. You're going to suffer from osteoporosis problem. That's one of the limiting factors for using GnRH analog, although it can be used as a second line. People think about using progesterone as less side effect. They start think about giving Depo-Provera. They start thinking about giving oral progesterone. The latest one in the market, like Dynogest, what we call it Vizan. Vizan, we're going to talk about the mechanism of action and how to use it, is the latest of the what you call it 4th generation progesterone used nowadays. It can be used up to 1 year. It is oral medication, but you should use it daily. What coming in future, the GnRH antagonists, they are now manufacturing a new oral antagonist form from, remember, the GnRH agonist and this GnRH antagonist. This is two different mechanism of action. The antagonist work immediate, whereas the agonist work after time. The antagonist new generations, it's not released yet. It's in the phase 3 trial now. It's an oral form. So the only oral form nowadays used is Dynogest. Dynogest is the Vizan, the trade name. It's steroidal. It is selective 4th generation progesterone derivative. It's giving orally once a day 2 milligrams. You can use it 6 months. People can use it up to 1 year. The half-life is 10 hours. So that's why is once a day is enough. And the advantage of using this new generation of progesterone, they have no androgenic side effect. Whereas the other progesterone tablets or injections, they have androgenic side effect. This is the one, they have no androgenic side effect. How it works? It suppresses the estradiol level, lead to atrophy of eutrophic endometrium. So the endometriotic lesion will be dry and peels off. But remember, once you do that, you suppress ovulation. It's anovulatory, it is suppress ovulation and suppress the endometrial line. So you remember the endometrial thickness depends on the estrogen secretion. When you suppress the estrogen, it acts on the uterus to suppress estrogen inside the uterus. Suppress estrogen at ovarian level, so anovulation. no endometrial growth. It has an anti-inflammatory action. That's why it works in the pain in the two sides. Shut down the estrogen and anti-inflammatory process action, because it's it has worked with the prostaglandin. So one of the good drug nowadays used is Bizan. Many papers published about using Bizan, randomized. Bizan came in the market, by the way, I think at 2010, 2011, at that period of time, when the full phase 3 trial done. Now the comparison as a second line management between Bizan and long-acting GnRH analog. Both of them work. This is the first trial, whereas the Bizan or the Dynogest start to select the right dose. They tested 2 milligram and 4 milligram. In this graph, you can see in all kind of pain, whether premenstrual pain, dysmenorrhea, dyspareunia, and diffuse pelvic pain, the 2 milligram and 4 milligram both effective in the same way. That's why they chosen the 2 milligram is the recommended dose. When you try to look at the studies comparing the Dynogest 2 milligram with the long-acting GnRH analog, this is study done over 6-month follow-up. They found that both have the same action, the same effect. So Lupron is injectable, sub-Q. It will be given monthly basis. If you use the regular long-acting, you can use the long-acting 3 monthly basis, 1 injection, or you can use Bizan or Dynogest 2 milligram once a day, but daily. So now they are both, you have to balance the side effect between the two. We know now the GnRH analog, the side effect over long time use, you have menopausal symptoms like hot flashes, you have osteoporotic, you have low estrogen, you have in your system from that side effect. Whereas the Dynogest have no androgenic side effect. You don't have with this the osteoporotic changes like the Lupron. But both of them, for the pain management, they consider at the second line therapy and they act the same. What is the side effect of Bizan? Many side effects, but they are minor. Headache is the commonest, cystitis, nausea like GI symptoms, nasopharyngitis, bronchitis, all this within 1 to 2%. Because it's progesterone, you have to warn the patient it may have fluid retention and weight gain. There is some reports that you have to check blood pressure frequently because this drug might increase the blood pressure. So they have to add up as the last side effect to that medication that blood pressure is a concern to that medication. So in general, this tolerable side effect is better than the side effect of GnRH analog. Endometrioma, there is now, people think that how we treat endometrioma, there is a debate between medical and surgical. We know now medical doesn't work in the endometrioma because endometriotic cyst has a poor blood supply. So whatever you give medication systematically, it will not reach to the endometrioma. People now try to work to see if I inject some local sclerotherapy to the endometrioma, like giving progesterone, suck the endometrioma under ultrasound guidance and inject progesterone. People think it works, but it still doesn't, the evidence is not convincing. Giving the intracystic treatment for endometrioma under ultrasound guidance or even under laparoscopical guidance, the evidence is not convincing. I'm going to stop at this point because of the time, and I welcome any question.
Thank you very much, Dr. Ahmed. I think there is a lot of questions in the YouTube and also in the webinar. So just only I'll pick one question. What is your recommendation for the patient with endometriosis and with repeated surgery when you will start for her Bizan?
That's why we tell it depends on how you counsel the patient at the beginning. When the patient comes, we'll counsel her, look, this is treatable, not curable. Once you start surgery, the recurrence rate is 50%. 50% is the recurrence rate over 5 years period. So if the patient have fed up with surgery, initially she thinks that the surgery might help and give you prolonged release, no medication, fine. But you cannot keep doing surgery, because surgery after surgery, it's going to be more difficult, more adhesion, more bowel injury, more complication. So in that kind of patient, I said you have to live with the disease, like patient with diabetes. Diabetes is lifelong disease. So you prescribe the medication for the patient, and it's going to be used for lifelong. You may have interrupted use it for 6 months, give a release, take a break for 1 month, and then resume again. For this kind of patient, medical therapy is the ideal for her.
Thank you very much. I think there are more questions in the YouTube and in the webinar. So if you don't mind, if you can answer it.
Go ahead. I'm the last one anyway.
Yeah, no, still there is one more lecture.
Is it?
Yeah.
Okay.
So thank you very much, and please answer it. I'll go for our last but not least speaker, Dr. Khalid Abdel Halim. He's the head of Women Health Care Therapy area. He's in Dubai. So welcome, Dr. Khalid. I know that he's in Dubai and breakfast is so close. Next time we'll go to you in Dubai, inshallah. He will talk about Dynogest, the smart choice of endometriosis treatment. Welcome, Dr. Khalid.
شكرا جزيلا دكتور سمير. السلام عليكم. بسم الله الحمد لله والصلاة والسلام على سيدنا محمد. تقبل الله منا ومنكم الصيام والقيام وصالح الأعمال، وبلغنا الله وإياكم ليلة القدر. I'm trying to share my screen. Can you see my slides now?
Yes, it's clear. Proceed.
Perfect. Thank you. So allow me to thank you first for the kind invitation, and special thanks to Dr. Ahmed. He made actually my presentation much easier. I'll try to avoid the overlaps between the two presentations. So Dr. Ahmed has nicely covered all the aspects of endometriosis definitions, and where the common sites are, and where the less common sites like lungs and the brain. And the association actually between the endometriosis and the infertility, we found like up to 40% of fertile women have endometriosis, and 30 to 40% of women with endometriosis experience infertility or subfertility. The relationship still not clear. And the delay in diagnosis actually can shift the endometriosis from just an individual impact like pain, for example, to a societal impact like impact on, for example, the relationship, the absenteeism, the less productivity, and so forth. That makes a rapid diagnosis is very crucial. That's why we all know that the gold standard in diagnosis still is the laparoscopy, the surgery, but nowadays the guidelines endorse the non-surgical diagnosis in certain situations. Like we have in the ISHRI and the Canadian guidelines. They endorse actually the use of progestin as a first line empirical treatment. And the goals of endometriosis treatment could be just as to relieve the symptoms like pain alleviation, or to treat infertility with ART techniques, preserve fertility, and prevention to progression to a chronic pain, and to minimize surgeries like the question before. Actually, we have to choose the ideal candidate who would benefit from the surgery, and when is the best time to do the surgery. And here we have to focus on the use of medical treatment after surgery to reduce the recurrence rate. Dynogest, actually, it's a progestogen from the 19-nortestosterone group. And here is the chemical structure of all the group. We can find all the group has ethinyl group in the position number 17 in all the progestogens, except Dynogest. It has a cyanomethyl group, not an ethinyl group. Another difference is a double bond here between carbon number 9 and 10. And these two differences which make Dynogest different from other progestogen. Mainly, it will not be having androgenic or glucocorticoid effects. On the contrary, it will have an anti-androgenic effect. And what is most important is the selectivity. This product has a moderate suppression on the gonadotrophin, so it allows certain estrogen. So it's not like the GnRH agonist or the medroxyprogesterone acetate that keep the estrogen level to the menopausal level. So we cannot use it more than 6 months. No, with Dynogest, we can use it for a long time because it does not suppress estrogen totally. It has a moderate central suppression on the pituitary and hypothalamus. And on the other side, it has a very strong local effect with anti-proliferative, anti-inflammatory, and anti-angiogenic effect on the endometriotic lesions everywhere. So with Dynogest, we can reach this window of estradiol level that is not below the 30, which can affect the bone turnover, or above the 50, which can stimulate the endometriotic lesion growth. Here is the anti-proliferative effect of Dynogest, and it's shown to be equal to GnRH agonists. And here is the anti-inflammatory effect of Dynogest. This anti-inflammatory effect is not shown actually with GnRH agonist, and with Dynogest, there is many explanations for this anti-inflammatory effect. One of them is the increase in the natural killer cells, and the other is the inhibition of interleukin-1 and the macrophage activities. A third mechanism for the anti-inflammatory effect could be through the inhibition of toll-like receptors. So we have here the toll-like receptor, the nuclear factors, and the interleukin. The third effect of Dynogest is the anti-angiogenic effect. And this anti-angiogenic effect is actually due to two main factors. Suppression of the VEGF, the vascular endothelial growth factor, as you will see in the next slide, and the other one is through the suppression of estrogen level. And this effect is mainly shown with Dynogest, not any other progestogen. This effect with Dynogest is 40-fold stronger than the effect of medroxyprogesterone acetate. Last effect is the prostaglandin E2 modulation. What prostaglandin is actually do with endometriosis, we found that prostaglandin is overexpressed in endometriotic lesions. And this upregulation of the prostaglandin can lead to upregulation of the local estrogen synthesis. So we work to suppress estrogen from the ovary, but in the endometriotic lesions, there is a local production of estrogen due to the high level of or high expression of prostaglandins. And this is done via the steroidogenic acute regulatory protein. Another mechanism that prostaglandin do in endometriotic lesions, it promotes cell proliferation through many growth factors like fibroblast growth factor 9 and through the abnormal matrix metalloproteinesis. The third one is the upregulation of vascular endothelial growth factors that allow new angiogenesis and allow the spread and the metastasis of endometriotic lesions from site to site. So here we can see that the nuclear factor can lead to stimulation of microsomal prostaglandin E2 synthase that lead to increase in the prostaglandin level. And this high prostaglandin level inside the endometriotic lesions can stimulate the aromatase enzyme to increase local production of estrogen. And this can lead to stimulation of tumor necrosis factor alpha and the other inflammatory cytokines like IL-8, IL-1, and so forth, and to a stimulation of the nuclear factor, and we get inside a vicious circle. What Dynogest do here, it actually block or inhibit the nuclear factor. It inhibit the microsomal prostaglandin E2 synthase. It block the cyclooxygenase or the COX-2, and it inhibit the aromatase enzyme. By doing that, it will decrease the prostaglandin E2 synthesis in the endometriotic lesions, and it decrease the aromatase enzyme. By doing that, it will reduce the estradiol level. The clinical development, it actually nicely explained by Dr. Ahmed, he has shown us this placebo-controlled trial with the 2 milligram, and just after 4 weeks, it leads to a 40% reduction in pain. And over 15 months, this effect is even improved and maintained. And in a head-to-head comparison with the leuprolide acetate, we have seen that both products have similar efficacy on all parameters, actually. So this one is studying the effect of Dynogest on the lesions itself, so not only on the pain or symptoms, but on the lesions. And we can see here that at baseline, more than 60% of patients have stages 2 and 3. And after just 6 months of Visan treatment, we can find more than 80% of the patients with stage 1 or even cannot detect endometrial lesions, and less than 20% with stage 2 and 3. This can prove a statistically significant effect on the lesions. This score as well, we can see more than 70% reduction in the lesion score according to the revised American Society for Reproductive Medicine. So it comes down from 11.4 to just 3.6. So a 7.8 reduction in the lesion score, which is statistically significant. Improvement in symptoms. This has been shown in Dr. Ahmed's presentation, dysmenorrhea, dyspareunia, diffuse pelvic pain, and the premenstrual pain. And this effect was similar to that of GnRH agonist or leuprolide acetate. In an article published at the 2017 about the Dynogest treatment after ovarian endometrioma removal in infertile women prior to IVF, we found that the clinical pregnancy rate in there were 3 groups: the placebo group, the GnRH agonist group, and the Dynogest group used 3 to 6 months before IVF. And we can find a clinical pregnancy rate like 45 in the Dynogest group compared to only 16% in the placebo group. And this difference is statistically significant. The same is for live birth rate, which is 36% versus only 11%. Quality of life is very important because, as Dr. Ahmed mentioned, this disease is not curable, but treatable. So patients have to live with them. So quality of life is very crucial. We can see here the physical and mental quality of life is significantly better with Dynogest versus leuprolide acetate. So if efficacy-wise on the pain and the symptoms is equal between the 2 products, safety and the quality of life is better with Dynogest. The safety aspects will mainly due to the hypoestrogenism side effects. So we can find more sleep disorders, vaginal dryness, and hot flashes in the GnRH agonist group versus the Dynogest group. And of most importance, the bone mineral density. It's not affected all over the 6 months of Dynogest treatment versus significant reduction in the GnRH agonist group. Same for the hot flashes. We cannot see hot flashes with Dynogest, whatever it's reported with the GnRH agonist. So in summary, Dynogest exerts an anti-inflammatory, anti-proliferative, and anti-angiogenic properties. The extensive clinical trials have shown efficacy and tolerability in endometriosis, and it is significantly improve the pain, lesions, and reduce the recurrence and improve IVF outcomes. The Dynogest is the only low-dose progestin that has been shown to be equally effective to GnRH agonist and to have a favorable safety and tolerability profile, and most importantly, it's suitable for long-term use. Thank you very much, and any questions?
Thank you very much, Dr. Khalid. Just I'll take one question from the webinar. They said, what is the maximum recorded time for use of Visan? Because she has 1 patient, she's using it for multiple years. So what is your answer?
The maximum now is 6 years. Still, there is some trials ongoing, but in Japan, there is a reported patients having the drug for 6 years. And there is an ongoing studies now to study it for 72 months and more.
Thank you very much. Now, thank you very much for your interesting talk. Just I'll open the discussion now. So if you want to say anything, then please, everybody, if you can, all the speaker answer your questions. So it will be great in the YouTube and in the webinar. So if you want to say anything, please say it before we close the meeting. And at the end, I would like to thank everybody. I'll thank all the speakers for their interesting lecture. Everybody is writing in the webinar that it's very interesting lecture. Thank you very much. Also, I'd like to thank Top House Conference for their help, and especially Mr. Ahmed. He's a man who's working behind the screen about internet and connection and so on. Thank you very much for everybody. If you want to say anything, any of the speaker, welcome please, before we close the meeting.
Shukran, Dr. Samir. Thank you very much, Bayer. Thank you very much for all the speakers and especially the audience. And كل عام وانتم بخير.
Thank you for having me.
Oh, it's our pleasure. Thank you, and want to see you again and again, inshallah.
شكرا دكتور سمير.
شكرا جزيلا جزاكم الله خير. السلام عليكم.
عليكم السلام ورحمة الله. I'd like to say thank you very much for everybody. We want to see you again, all the participants, inshallah, in our next conference, which is up in 3rd International Conference, which is going to be end of November in Riyadh with live surgery. So see you there by the end of November in Riyadh, inshallah.
شكرا دكتور سمير وشكرا دكتور هشام عرب وكل السبيكرز. ميتنج رائع، متشكرين جدا جدا لحضراتكم. شكرا.
Thank you very much.